Good morning, good afternoon, and good evening to all of you joining us from around the world. My name is Krishna Udaykumar. I'm the founding director of the Duke Global Health Innovation Center at Duke University. It's my pleasure, on behalf of all of the implementing partners and sponsors, to welcome you to this virtual event for the COVID Treatment Quick Start Consortium. COVID-19 continues to cause preventable deaths, hospitalizations, and suffering around the world while threatening to overwhelm health systems and economies in the midst of future surges. We have a growing arsenal of tools that are available to fight COVID-19, including oral antiviral treatments to complement vaccines and other interventions. Unfortunately, many of those who have the most need, especially in low and middle income countries, are unable to get timely access to these tools. Over the next few minutes, we will hear about the aims, the ambitious goals and plans, and the public and private partners coming together to form the COVID Treatment Quick Start Consortium. I have the honor of moderating our session today. We'll be hearing from our country partners, our implementing partners, and sponsors. After those remarks, we'll have time for questions and answers. Thanks to many of you who have sent questions ahead of time. We will continue to take questions, so please do ask more questions along the way by using the Q&A tab in Zoom. With that, I will try to get to as many questions as we can after our remarks. And I'd like to first introduce now Mr. Gary Edson, President of COVID Collaborative, to provide an overview of the consortium. Gary, welcome.
Thank you, Krishna. Let me briefly put Quick Start into context. The Quick Start Consortium is the first concerted effort to bring new, highly effective COVID oral antiviral treatments to low and middle income countries. This effort will complement those of the US government and multilateral organizations with whom we've been closely coordinating. Quick Start brings together the COVID Collaborative, Duke University, AmeriCares, the Clinton Health Access Initiative as implementing partners with the support of the Open Society Foundations, Pfizer, and the Conrad Hilton Foundation. This 18-month project will kickstart programs through a donation by Pfizer of 100,000 courses of Paxlovid. These programs will transition to low-cost, quality-assured generics as they become available. It's important to emphasize that Quick Start is first and foremost a public-private partnership. We will be working hand in hand with Ministries of Health to build public sector capacity for COVID test and treat. Our partner countries are an intentionally diverse group, including 9 in Africa: Ghana, Kenya, Malawi, Nigeria, Rwanda, South Africa, Uganda, Zambia, and Zimbabwe, plus Laos in Southeast Asia. Quick Start's goals are threefold. First, as I mentioned, we'll partner with Ministries of Health to rapidly introduce and scale access to new COVID oral antivirals for high-risk individuals with mild to moderate symptoms within 5 days of symptom onset. We expect treatment to start reaching the first patients in select partner countries this month. Second, we'll establish a learning network open to all interested parties across countries and sites. This will enable us to share learnings and best practices in near real time to inform additional country programs. And third, we'll help build sustainable COVID-19 outpatient test and treat programs with access to low-cost, quality-assured generics. We will be working actively to facilitate market entry of those generic equivalents. With this three-part strategy, we believe that Quick Start can be a game changer. As many of you will recall, it was early catalytic efforts like Quick Start that paved the way for widespread access to HIV oral antiviral treatment. Similarly, by demonstrating convincingly that COVID test and treat is feasible in low and middle income countries, Quick Start should allow for national scale up beyond our partner countries. In so doing, Quick Start will help ensure more just, and more equitable access to these life-saving therapies. Back to you, Krishna.
Thank you, Gary, for sharing that exciting vision that's brought us all together here today. Let's turn next to Professor Claude Muvunyi, who's the Director General of the Rwanda Biomedical Center, to provide a country perspective of the work and its value. Professor Muvunyi, welcome.
Thank you very much, Dr. Krishna. Dear partners and all protocol observed, I think it is a very great honor for me on behalf of Rwanda to attend this important event where we are going to launch this COVID-19 therapeutics. To give a little bit about Rwanda, I think over the last decade, Rwanda has made tremendous progress in improving the quality of health of the population and has emerged as a leader in healthcare in the regions. And the ratio health coverage index increased by almost 31 percentage, and the under 5 mortality dropped from 76 deaths per 1,000 live births in 2010 to 40 per 1,000 live births in 2020. And the rate of fully immunized children increased by 6.6% in the last 2 decades, with more than 96% of the children receiving essential vaccines. However, these efforts have been heavily disturbed by the COVID-19 since March 15, 2020, when the first case was identified in the country. So in response to the pandemic, Rwanda has optimized the knowledge and capacity in place to minimize the number of lives lost. And since the beginning of the pandemic, Rwanda's approaches to monitor and respond quickly to the pandemic has been through testing, guided by a national testing strategy that mainly focused on increasing access to the COVID-19 diagnostic services across the country through the scale-up of and also optimization of diagnostic services. This strategy has been continually revised and upgraded as more testing platforms come on the market to ensure access to the best quality and price. The country's flexibility and openness to the pandemic has allowed Rwanda to introduce rapid antigen testing in December 2020, which also revolutionized the COVID-19 testing in the country by increasing access, shortening result turnaround time, and also reducing the burden on healthcare workers. So the introduction of COVID-19 pandemic, despite limited access and inequity in vaccine availability, Rwanda managed to introduce COVID-19 vaccine in March 2021, and since then, 100% of eligible population have received the first dose with 98% fully vaccinated with the 2 doses, and over 60% experiences a total of 1,411 deaths, which makes around 1.1% of total cases that we registered in Rwanda. With this introduction of COVID-19 therapeutics, it comes as an additional intervention to further reduce COVID-19 mortality and morbidity, and most importantly, reduce the transmissions. It is important that as we introduce the treatment, we plan for long-term integration of the services in our routine and primary healthcare to ensure sustainability. Rwanda's approach remains the same, and also in the shortest time, while minimizing the cost through integrations. We are very grateful for all the partners who never cease to support us since the beginning of the pandemic till now, working together to find more effective life-saving solutions and interventions to the pandemic. I'll also take this opportunity to greatly appreciate the catalytic donations of COVID-19 drugs to Rwanda from the Consortium, and this will help the country to quickly introduce the drugs in Rwanda while exploring long-term procurement and rollout plans. And finally, I thank you and wish you a fruitful event.
Thank you, Professor Muvunyi. It's been fantastic to have a chance to partner with the government of Rwanda and also to see the leadership role the government has played in addressing COVID-19 over the last 2 years. Of course, the work of the COVID Treatment Quick Start Consortium wouldn't be feasible without the generous support of our sponsors. I'd like to turn now to one of those sponsors. We will hear from Ms. Rosalind McKenna, Special Advisor to the Open Society Foundations, to talk about the importance of catalyzing action to address urgent issues. Rosalind?
Thank you, Krishna, and thank you to the hosts for having us here today and to facilitate this important discussion about the potential of the Quick Start Consortium. I think we are all agreed that COVID-19 really exposed the massive inequities in access to vaccines, to testing and treatment, and other key health commodities. Many of those inequities existed prior to this pandemic and will continue to exist without structural change, but certainly those inequities were brought into stark relief by COVID-19. Open Society Foundations is really delighted to support the Quick Start programme to address this urgent gap in testing and treatment availability, and really to demonstrate the viability of timely access to diagnostics and low-cost antivirals as we hope to end this pandemic or more effectively manage the virus. Open Society Foundations are the world's largest private funder of independent groups working for justice, democracy, and human rights, and we provide thousands of grants every year to a network of organizations across the world facing critical human rights and open society challenges which are profoundly shaped by the current pandemic. I think that the catalytic nature of the Quick Start programme is really based on our core belief on the need to model and support and shape interventions that really help to guide the systems to be more effective and to deliver for vulnerable populations. And I just wanted to touch on some of those key aspects of the catalytic nature that we were particularly keen to support through our funding for Quick Start. I think, as Gary mentioned, this point around the learning network, certainly this access to diagnostics and treatment for vulnerable populations is the most humane and human important part of the intervention. But the way in which the programme will shape the systems, the protocols, the supply chains, the integration with primary healthcare systems, in order that these interventions can be scaled up and replicated elsewhere, is a huge reason for our interest and belief in this group of partners. And similarly, I think the role that the consortium can play in engaging with the wider development and health community to ensure that the lessons from this are taken into other donor agencies, are taken into other large-scale programs as we move into pandemic management, is really a core opportunity. And it's great to hear the country experiences of how they plan to utilise the Quick Start partnership. I did want to zoom out one moment from this particular project and COVID response. We're obviously in a moment of converging and colliding crises: food, energy, debt, climate, COVID. But I think what we are seeing is that there's a huge public demand for this scale up of structural interventions to support these crises. OSF has launched today a new report, Fault Lines, Global Perceptions on a World in Crisis, looking at the level of public support for more effective international action to address the crises we collectively face. And I think that's an important lesson for Quick Start and other interventions in this space. We need greater political action. We need greater financing for these kinds of systemic interventions that build buy-in and models for elsewhere. I really just want to close by thanking the COVID Collaborative, thanking Duke, thanking Chai, and also thanking Pfizer and the Hilton Foundation as other co-sponsors of this intervention, and in particular thanking the country leaders that are going to be moving forward with this programme. We wish you all the best and are excited to see how the lessons from this can be replicated elsewhere. So I will stop there. Thank you, Krishna.
Thank you, Rosalind. Fantastic to have support from the Open Society Foundations and be able to use that really as a catalytic model to bring this entire consortium together. Let me turn now to Mr. Sean Regan, who's the Associate Director for Viral Hepatitis and Coordinator of COVID-19 Therapeutics for the Clinton Health Access Initiative, our core implementing partner. Over to you, Sean.
Thanks, Krishna. And thank you to Prof. Claude and Prof. Malenga, who joined us today from Rwanda and Zambia, whose presence really speaks to why this consortium is so important to CHAI. At CHAI, we believe that no one, no matter where they live, should die for lack of access to healthcare. And, CHAI and our Quick Start partners are committing to correcting the injustice of life-saving COVID-19 tools being disproportionately available to those who live in high-income markets. This program will provide governments with catalytic access to the drugs and technical assistance they need to quickly scale up COVID testing and treatment to reach those who need them most. And through Quick Start, CHAI will support 10 of our Ministry of Health partners to rapidly introduce and scale access to these newly developed, highly effective COVID-19 oral antivirals in high-risk populations. As Gary said, the 10 countries are Ghana, Nigeria, Rwanda, Kenya, Malawi, Uganda, Zimbabwe, Zambia, South Africa, and Laos. And I couldn't thank you all enough to our teams that have worked so diligently to get this work going together with our Ministry of Health partners. In close collaboration with these Ministries of Health and other in-country implementers, CHAI will provide strategic and technical support that encompasses all key programmatic aspects of effective diagnosis and treatment models. Specifically, CHAI will work on drug registration efforts, securing waivers where necessary to ensure that best-in-class products are available to countries when they need them. We'll support on updating clinical guidelines and sharing the latest relevant science updates as they develop. We'll work on training plans and materials and job aids and tools to support the health workforce as they look to integrate these new services into ongoing workflows. Integrating the new drugs into existing HMIS and pharmacovigilance systems will also be really key to making sure this program works well. We plan to start fast, but we also want to take a longer lens to the work and support our Ministry of Health partners through technical working groups on national level planning and costing efforts. And this really includes budgeting and procurement planning for inclusion of programming and commodity requests through C19RM, which will be really, really important to the longevity of this work. Lastly, a key role for CHAI to play on the drug side will be engaging with our MOH decision makers and partners and community leaders to align on our introduction and scale strategy as we get going here. Integrating the treatment activities with ongoing antigen testing at the country level will also be incredibly important to the effectiveness of our work. On the testing side, we'll continue to support our MOH partners as we have done for the past few years on national testing strategies and updating testing protocols, on selecting and activating new testing sites, training of the healthcare workforce on testing protocols, strengthening quantification and procurement and supply chain for test kits. And all of these efforts should really include and have an emphasis on the introduction and scale of self-testing. Programs will kick off in the coming weeks with donated product from Pfizer that will act as a bridge to quality assured low-cost generic equivalents when they become available, facilitating nationwide decentralization, scale up, and sustainability. And I should say that back in May, CHAI negotiated a ceiling price with several leading generic firms for nirmatrelvir ritonavir of $25 per course. CHAI will work to activate in the next couple of weeks several initial treatment and testing sites in each country and begin generating actionable data and lessons learned to support implementers in making evidence-based decisions so that they can course correct as needed and things change on the ground. As the work progresses, we'll continue to evaluate project implementation and disseminate key learnings through our learning network and really try to inform additional lower middle income country programs that are trying to establish similar programs to ours. We can't do this alone, and we really welcome and want to take this opportunity to welcome other partners to join us within our Quick Start Consortium. And really to stay true to our name, Quick Start, we need to get access to drug quickly. Our partners at AmeriCares are vital to the drug access effort, and we'll be facilitating the process of getting donated Paxlovid to our program countries very quickly. Let me turn it over to them so they can speak to their plans and their role that they're going to play in the Quick Start Consortium. Thank you.
Great. Thank you, Sean. Let me now bring in Ms. Christine Squires, President and CEO of AmeriCares, to talk about the important work that AmeriCares is doing as part of this consortium.
Thank you, Krishna. So throughout every phase of this pandemic, there has been one constant, which is inequity. There have been disparities in who gets the sickest, which is linked to who has access to supplies and vaccine, and who has access to treatments. Low and middle income countries still lack equitable access to critical life-saving treatments, and we seek to change that. As a relief and development organization focused on saving lives and improving health, America's COVID-19 response has been supporting health workers serving the most vulnerable populations. We provide access to training, mental health support, credible vaccine information, staff to alleviate personnel shortages, and critical supplies like personal protective equipment. AmeriCare's COVID-19 response has spanned 46 countries, providing over 18 million gloves, masks, gowns, and supplies, and also supporting vaccination campaigns in multiple countries. Over the past 2.5 years, we've all seen COVID-19 pandemic impact the health of hundreds of millions of people and claim over 6 million lives. More than 1 million people have died of COVID-19 this year alone, and we need every tool available to slow that spread. It's critical we continue to respond to this health emergency with urgency and equity. And though many are experiencing pandemic fatigue, we must remain vigilant in our efforts to lessen the impact of COVID-19 on communities all across the world, especially low and middle income countries that lack equitable access to medicines and supplies. Now we're pleased to partner with Clinton Access Initiative, CHI, and the Consortium on the next component of our response to make antiviral treatments accessible to patients at high risk of severe illness and death from COVID-19. AmeriCares is a leader in the delivery of donated medicines and medical supplies, and our role in this effort will be to leverage our experience in the logistics and distributions of pharmaceutical products to deliver antiviral treatments to Ministries of Health in 10 countries that were mentioned just earlier. Our efforts, combined with CHI's medical and technical expertise to support the Ministry of Health rollout, will make life-saving therapies available to vulnerable populations who still lack access. We're also thrilled AmeriCare's longtime partner, Pfizer, is supporting this effort and jumpstarting the campaign with a very generous donation. We know that high rates of chronic disease in many of these participating countries make patients more at risk of severe illness or death from COVID-19. And by expanding access to testing and treatment, we will be taking a more equitable approach to reduce hospitalizations and severe disease and ultimately save lives. The COVID Treatment Quick Start Consortium will make treatments available to patients in need and give hope to those most at risk. I really want to thank you all for your partnership in this important effort.
Great. Thank you, Christine. Let's turn now to another country perspective. And it's my pleasure to welcome Professor Lloyd Malenga, Director of Infectious Diseases for the Ministry of Health in Zambia. Professor Malenga, welcome.
Thank you so much, the Quick Start Consortium. On behalf of the Ministry of Health, we are really grateful. We have been struggling with where to find resources for management of COVID, just as we also struggle for management of certain conditions. And when we had Paxlovid approved, we wondered how we can access such commodities. So the Quick Start Consortium really is something that we had been looking forward to. And for us to be able to treat the so many individuals that are suffering from COVID and also the effects of COVID is something that we are grateful for. As a country, during the COVID pandemic, we started setting up what are called post-acute COVID clinics, especially during our fourth wave, where we had the major variant of Delta ravaging the population. We have had these clinics set up across the country, and we intend to use these as the platforms for the test and treat for COVID. So really, this gesture has come at the right time when we have at least the basic systems available. We have, with support from CHI, also updated the guidelines. We also have been running some clinical outcomes study with support from CDC. So we brought together also our local partners to help support the rollout of Paxlovid in the test and treat concept. So we are really grateful as a country, and we hope that the lessons that we are going to learn during this period are going to move us forward in how to roll out to the general public, and that other countries may also try and learn from this. With this, I would just like to say thank you to the consortium. We hope that working together, we'll be able to save so many lives and also help to avert a number of morbidities and a number of admissions which we've been experiencing. Thank you.
Thank you, Professor Malenga. It's an honor to work with you and partner with the Ministry of Health in Zambia to roll out this program over the coming days and weeks. We'll now turn to Ms. Caroline Rowan, Senior Vice President for Global Health and Social Impact and Chief Sustainability Officer at Pfizer, another generous sponsor of this consortium. Caroline, welcome.
Thank you, Krishna. It's such a pleasure to represent Pfizer here today. Since the start of the pandemic, Pfizer has been committed to delivering both treatments and preventative solutions for those patients, regardless of where they live. And we believe that oral antivirals do play the potential to be a game changer when they serve as a complement to vaccines. And we have remained committed to enabling access for all those who can benefit from them. Now, the first step in that process, of course, is to secure supply. And to do this, we have developed a comprehensive strategy working both in partnership with governments, but also global health leaders and global manufacturers to optimize overall supply and access in all parts of the world. One critical first step in this plan that we were so proud to announce was a voluntary licensing agreement with the Medicines Patent Pool, which will facilitate additional production and distribution of generic versions of our oral treatment to 95 countries, covering approximately 53% of the world's population. But I think, as you've heard in the discussion today, facilitating global supply is only the first step. We've seen firsthand during this pandemic that the challenges we all face with a global rollout of both vaccines as well as treatment goes well beyond just supply. So therefore, it's critical that we all work together to look for solutions to these broader health system challenges, which I think we all are far too familiar with, like logistics, diagnostics, training, education, the things that really, in some cases, can serve as bottlenecks to getting those treatments supplied and out to the patients who really need them. So specifically, oral treatments are interesting because, as discussed, they're recommended to be administered within the first 5 days of onset of symptoms. So identifying the best pathways for sufficient testing, diagnosis, and of course, delivery of these treatments becomes critical to ensure timely and equitable access to the COVID therapeutics. So we have to develop these tailored approaches, working with the specific needs as outlined by our country partners, and develop those insights, as we've discussed, rapidly sharing them so we can inform future responses. Now, we're so thrilled that addressing these challenges we can do with partners, because we depend on our partners to address this pandemic and have so since the beginning. And we're so proud of the collaboration with the consortium. The deep experience and knowledge that you see here today is really focused on rapidly bringing evidence-based test and treat practices to countries to close that gap in access and to help fight COVID-19. We believe so strongly in the mission and are incredibly proud to support these efforts with both a financial contribution and, as discussed, early access to a donation of 100,000 courses of Paxlovid to conduct the test and treat pilots in the 10 countries and hopefully catalyze that access to all therapeutics more broadly. Now, our purpose at Pfizer is to deliver breakthroughs that change patients' lives, but we know that they're only effective when they actually reach the patients who need them. So I really want to thank Duke University, the COVID Collaborative, our partners with the Clinton Health Access Initiative, and AmeriCares, of course, for their longstanding work to address some of the challenges in global health, but specifically their leadership here around COVID-19. We do believe that better health is possible for everyone, everywhere, and that all people deserve access to quality healthcare. And we're so proud to stand in partnership with you in support of this consortium. Back over to you, Krishna.
Thank you, Caroline. And thanks to all of our partners for their perspectives and their commitment to this important work. We'll now turn to questions. As I mentioned before, please use the Q&A tab in Zoom to continue to send us questions, and we will try to get to as many as we can. We've had a couple of questions that I'll first turn to Gary Edson at the COVID Collaborative to give us a bit more perspective. You mentioned about engagement with the US government as well as the multilaterals, including the Global Fund, UNITAID, and others. If you could tell us a bit more about how we envision this work relating to those other efforts and complementing those as well.
Thank you, Krishna. It's an important question. We have been coordinating and collaborating with USAID and with multilateral organizations almost on a bi-weekly basis as we've evolved our strategy, as we've selected our countries, and as we've developed our protocols. And we have shared those experiences and our thinking with those organizations so that we can ensure that the efforts of the various organizations that will be engaged in test to treat programs are additive and complementary and not duplicative. It is interesting that I believe what's going to happen is that in terms of country coverage, there is going to be a less overlap than people might have imagined, which is a good thing, so that we're going to cover collectively more countries together. But where there is overlap, our teams are working together on the ground to ensure that there is no duplication of effort and that there is a straight pathway forward to share learnings and to share experiences and to coordinate closely with Ministries of Health.
Great. Thank you so much, Gary. I'm going to turn now to Sean Regan at CHI for a question we've gotten about how the country selection has worked so far. We've named a couple of times the 10 countries that have been prioritized for the consortium as country partners, but perhaps you could speak a bit more about the model of CHI, the in-country teams, and the long-term engagement that's allowed us to develop these partnerships so quickly.
Yeah, thanks, Krishna. And you said it. I mean, the countries that we're at least starting out to work in, we have a long-standing CHI presence on the ground with CHI members directly supporting the Ministries of Health there day in and day out. For this project, aside from them being, countries where CHI has a presence, we also want to have that strong commitment from our MOH partners to get this new product introduction work off the ground quickly, and also to do the operational research that we have planned so that we can, learn and share those learnings outside of these contexts, but then also use them within the actual country context to help them scale. I should say we're always looking to expand, so I mentioned during my remarks that we want to welcome more partners and others to join the consortium. So hopefully, the work isn't meant to be contained within the 10 country footprint that we've outlined here. That we want to go further. We want our impact to go beyond these countries. So just to note that as well. But it really comes down to where we have a CHI presence, where we have that commitment from our MOH partners, and who have agreed, thankfully, to work with us on this.
Thank you, Sean. We have a couple of questions that I'd like to bring in our Ministry of Health colleagues from both Rwanda and Zambia to help us with. And that's really about both how you're thinking about the access to these treatments within the context of your local health systems. And secondly, related to that, how these efforts are envisioned to help support test and treat more broadly beyond COVID, as well as strengthen aspects of health systems over time. So Professor Muvunyi, maybe I could ask you to start.
Thank you very much, Krishna. And this is really a very good question. In Rwanda, I think we have made sure that we have mobilized through our domestic financing model to really get additional some doses of Paxlovid for really making sure that we do have the medicine available to really treat cases which need treatment. And I think with our commitment with the government and also with our decentralization of the testing capacity, we have been able to make sure that we have a system in place in terms of really having testing capacity from the central level until remote health facilities, where we do have at the remote level, we have available testing using antigens, and also when there is a need to sample to be shipped to central level, where we have some capacity for molecular testing also. So this testing capability has been decentralized to the sense that it's really now accessible to the patient who is symptomatic and also who's need of this treatment. And then with this already capacity, I think it's already very easy to introduce treatment, and we have been also been able to work with our partners to develop guidelines to really implement this Paxlovid. And then this opportunity comes to really support us in really continuing to gather some additional data in terms of really monitoring the treatment, but also to prepare for also scaling up this test and treatment to the whole efficacy in one. Thank you.
Thank you very much. And maybe I could ask Professor Malenga to add as well.
Thank you so much. Indeed, we have looked at where should we be putting a lot of effort in our rollout of the test and treat for COVID. We've looked at the geographical distribution of where we have the high burden of COVID from the time we had the first cases up to now. And even the first sites that will start implementing in are sites which are representing those areas where we think that there's greater need. But also we are cognizant of the fact that sometimes we can leave the rural areas, and the rural areas we've deliberately also picked some sites which are in the rural setting, because implementation in such areas may be different from the peri-urban and also the urban areas. We are working now on a policy of having the private pharmacies and also the private sector to be involved, so that we can also reach out to many more people, especially those who are in the high density areas who may not even have access to many healthcare facilities. So we are trying to do as much decentralization as possible. And it has come at a time when the Ministry of Health and the government at large is decentralizing many services. We have also now tried to look at how do we start quantifying for these molecules in our national quantification. And we've been in the next quantification happening in November. We are including Paxlovid. Hopefully in the coming few months, we should have a generic version, so that moving on, we should have those commodities as part of the essential medicines to be procured for under the routine procurement in government. Thank you so much.
Thank you, Professor Malenga, for that very helpful response as well. I'm going to turn next, Sean, back to you. We have a question asking for more details about the work in Laos, including the partnership and some of the experience Chai has had there to bring to this partnership.
Yeah, thanks, Krishna. So I might tie that question about Laos also into another question about sustainability for the program and funding. So, in Laos, our country team has been working really closely together with our MOH partners and also our Global Fund partners in country to develop a plan and really look at and build that off of a bit of a readiness assessment to understand where they are currently with access to testing and the gaps that remain to actually introduce treatment. So they're in a process of actually understanding what steps they need to introduce test and treat in the public sector, and then also the funding that's going to be required to make that happen. They're putting together this comprehensive plan, and they're really working closely with their Global Fund partners to try and secure those resources through C19RM, which is the funding source available for this programming and these commodities through the Global Fund. And I want to link that to that question that we also got about Kenya and sustainability. What I really want to mention is that we need long-term secured funding for these programs to support Ministries of Health to implement them and scale them up. And a critical step to being able to do that is actually understanding the state of play at your country level and putting together a plan to propose to our Global Fund partners and working closely with CCMs and portfolio managers and the country teams within the Global Fund and the Secretariat to make sure there's solid alignment around those plans so you can actually access resources to put towards this. So I would really encourage everyone on the call to engage in any way you can on that process, to work on readiness, work on those plans, and make sure that they're costed out into the future. So, to tie it back to Laos, I think Laos is in a great position to work with us to quickly get this program off the ground, but they're also looking towards that longer view of sustainability and bringing in the commodities and the programming support that they need.
Great. Thank you, Sean. We've got a couple of questions asking about the learning agenda, the learning model, some of the economic analyses perhaps associated with that. I'll start a response and ask others to jump in as they would like as well. Really, the basis of a lot of our work is to ensure that we're catalytic in its implementation, as well as the learnings that we can produce that enable more ministries of health, more governments, and more bilateral and multilateral actors to be more effective and efficient in their own introduction and scale up of these programs over time. We envision rolling out immediately a learning platform across sites, across countries, that will be open to anyone to participate, where we can start to generate that implementation science, the operational research insights about what it takes to stand up test and treat capabilities, what it takes to get new product introduction done effectively and efficiently, to train the workforce, and to start to see these programs ramp up. Secondly, over time, we will also be adding some observational data collection and analysis that will enable us to start to get signals around safety and effectiveness, and to ensure that we have an understanding of the populations that are getting access to these treatments in various countries and in various settings. All of our work will be done through a review of appropriate institutional review boards, as well as ethics committees, both globally as well as in every country we'll be operating in, and will be designed jointly with each of our ministry partners. So that's what we envision really as a core part of the learning that is going to come with this as well. Let me turn to a next question here, which is maybe I'll turn Sean. This is I think asked for a recap, and perhaps we can add this in chat as well. If you can remind us of the 10 countries that are initially on board.
Right. So yeah, I think Jessica's adding it to the chat, but it's Ghana, Nigeria, Rwanda, Kenya, Malawi, Uganda, Zimbabwe, Zambia, South Africa, and Laos.
Fantastic. We've got a couple of questions here about how we'll work with our country partners to identify which high-risk populations, and ensuring especially that vulnerable populations might get access. So Sean, perhaps you can start with that, and again, I'd like to bring in our colleagues from Zambia and Rwanda for that question.
Yeah, so I'll go ahead and start, and then throw it to Prof. Claude and Prof. Malinga. I think what we want to do is within each country, there's going to be discussions about priority populations, all within the high risk umbrella. We're going to be working with our country partners to update guidelines and training plans off the back of that, and job aids and tools, like I mentioned in my remarks. Prof. Claude, I think, is also looking forward to some training activities that are actually going to start later this week or next in Rwanda. But we really want to contextualize this, right? And not look at every country as the same. Like, the profile of high-risk populations is just going to be different. And so, Prof. Claude, maybe I can throw it over to you to speak about your approach here in Rwanda, and then maybe we can go to Zambia after that.
First of all, I think we are doing that not for the first time, because we have been used to scale up some previous treatments for cases, and then we are going to use the same system, the same expert in terms of really implementing the treatment. So we have really already designed or developed guidelines where we define clear criteria for treatment, especially for high-risk patients. And this has been already done, and we are very soon starting to now have training of clinicians, and also to cascade the training to the facilities where nurses and also facilities doctors will be trained on those criteria for treatment. There'll be continuous mentorship and also support to the team to really continue to provide this treatment to the really most needed population of patients. So this is a process that we are doing not the first time, because we have been able to implement some of the treatment in the past. So we're going to leverage on the team which are there, which are really dedicated to that, but also on the guidelines which are there to just adjust the guidelines that probably match to the test and treat protocol that we are going to implement. Thank you.
Thanks, Prof. Claude. And Prof. Malinga, maybe throw it to you now. Could you also say a few words about, the actual messaging to high-risk cases and how we help them to understand, how they'll be able to access testing and treatment in the future? That would be interesting to hear from the Zambia perspective.
Yeah, so from our perspective, again, as Rwanda has indicated, we have these high-risk populations identified. We have updated our guidelines. Then we are using also remdesivir before, monoclonal antibodies, and we had also populations. I think what is different, intravenous drugs which had been giving remdesivir and monoclonal antibodies, it's how do we roll out now these to the communities outside the facility settings. We off work as well for a prolonged period of time. So our selection for the risk categories are fluid, and they're also dependent on the local risk factors as well, including HIV, of which a number of people have been affected with COVID as well. So we have selected the risk factors according to how our pandemic did affect us, and also looking at other comorbidities and other conditions that do exist in country. Thank you.
Great, thank you all. There's a clarifying question that's come in just on this topic of how the criteria may be the same and what might be different country by country. So Sean, perhaps you could just clarify the process by which the protocols will be adapted for each country and context.
Right. Krishna, I don't know that the high risk categorization will necessarily be different, but there may be a different degree of prioritization in terms of rollout and what populations are initially targeted with some of the limited resources that are on the ground, right? This is always with a look towards scale and making sure that all high risk populations are covered under the program. But there is going to be some discussion on each country to define that, but really looking towards I think what we all understand as the high risk definitions as they stand now, but just making sure that we also take that local lens as well, as Prof. Malenga and Claude said.
Great, thank you. We've got a question about engagement of civil society organizations, and maybe I'll start by just noting that we do envision and have already begun consultations with and engagement with civil society organizations at the global level, as well as regional and local levels, and see that as really critical to this work, both to ensure that there's widespread confidence in programs as they're being co-designed, as well as to ensure that we're working collaboratively with civil society and other sectors to ensure that there is planning for larger rollout and scale up of these programs over time. So we've got another request, if we can just make sure we're adding the country list in the chat, which we will do as well. I think we are nearing the end of our time. I know there's a few more questions coming in, but we will certainly do our best to follow up and to make sure we continue to answer as many questions as we can. So as we near the end of our time, I'd like to thank all of you for participating today. Thank you to all of our speakers, the implementing partners, our country partners, and our sponsors. Thanks to everyone that's had a chance to join us here today. As you've heard, we're all excited to grow this public-private partnership through the COVID Treatment Quick Start Consortium in order to scale up access to test and treat capabilities, including access to affordable, quality-assured oral antiviral treatments. We invite you to join us in this important work. This is a consortium that's envisioned to be broad and growing over time. We plan to continue to expand over the coming weeks, and you can learn much more about the work of the consortium at the website link that was shared in chat, and contact us to learn more and also to find ways to collaborate and contribute. So thank you all for joining us. Good morning, good afternoon, and good night to all of you.